Hello friends, today we are going to discuss the biomarkers in acute kidney injury. So we'll first see the classification of acute kidney injury, that is rifle classification. So according to this classification, the risk is increased creatinine level by more than 1.5 or decrease in GFR by 25%. Urine output criteria is less than 0.5 ml per kg per hour for 6 hours. Then injury, that is increase in creatinine level for 2 times and GFR decreased by more than 50%. Then urine output criteria is less than 0.5 ml per kg per hour for 12 hours. Then failure is increase in creatinine level for 3 times and GFR decreased by more than 75% and increase in creatinine level for increase in creat of more than 4. Urine output criteria is less than 0.3 ml per kg per hour for 24 hours or anuria for 12 hours. Then loss is persistent acute renal failure or complete loss of renal function for 4 weeks and end-stage renal disease for more than 3 months. So acute kidney injury is the multifactorial syndrome which is characterized by rapid deterioration of kidney function and a high risk of short and long-term complication, effects and the quality of life and increased healthcare cost. Despite its frequent occurrence, there are no specific therapies and only limited diagnostic tool used in routine clinical care. So traditionally, AKI is diagnosed by rise in serum creatinine or fall in urine output, independent of underlying etiology, pathophysiology and anatomical site of injury. So both serum creatinine and urine output, these are marker of kidney function with important limitations. So limitations of so we'll see why serum creatinine and urine output are not that useful in diagnosing AK. So what is problem with serum creatinine? So first of all, serum creatinine is insensitive to the kidney damage. So nearly 50% of kidney damage should happen before serum creatinine increase. So second limitation is serum creatinine is very slow to increase following insult. Then it is affected by exogenous creatinine intake. It is dependent on the muscle mass, metabolism, and liver function. Then it may be affected by physiological and analytical variability. It can increase without true change in the renal function. For instance, in the setting of drug-induced inhibition of serum secretion, for example, cimetidine, trimethoprim, and hemoconcentration, that is dialysis. It may be altered during pregnancy. Then urine output, there is transient oliguria, it may be physiological. It can be manipulated by the diuretic and it is prone to measurement error even with the urinary catheter. So in some cases, injury to the renal epithelial cell may not even manifest in functional change and AKI remains undetected. That is subclinical AKI. Thus, reliance solely on the changes in the serum creatinine and urine output ignores the subclinical AKI and may delay the recognition and management of AKI and potentially contribute to the unfavorable outcomes. Now why creatinine is not useful for the diagnosis of AKI? So the serum half-life of creatinine increased from about 4 hours to as much as 24 to 72 hours as a GFR decrease. Thus, serum creatinine concentration may take 24 to 36 hours to rise after kidney injury. Further, in patients with sepsis, liver disease, fluid overload, and muscle wasting, reduction in GFR may not be accurately reflected by serum creatinine and may be additional delays. So, in post-hoc analysis of fluid and catheter treatment trial showed that AKI was revealed and classified differently in up to 18% of patients after serum creatinine results were adjusted for net fluid balance and estimated total body water. In addition, risk of delayed diagnosis and AKI may also be erroneously overdiagnosed. For instance, if the patient is taking drugs that increases the creatinine availability or compete with the tubular secretion, that is cimetidine and trimethoprim, then that will cause the false rise in creatinine. Then the next is we'll see what are the shortcomings of the urine. Lastly, urine production does not correlate with the GFR and may persist until renal function almost ceases. Further, oliguria may be appropriate physiological response during period of hypovolemia, prolonged fasting, after surgery, following stress, pain, and trauma. On the other hand, the use of diuretic can increase urine output in patients with AKI without affecting survival. Now, adjunctive AKI biomarkers. There are three broad categories of the urinary biomarkers. So the first group include biomarkers which have low molecular weight and freely filtered at glomerulus. For example, beta-2 microglobulin, lysozyme, alpha-1 microglobulin, light chain, and cystatin C. So under normal circumstances, these molecules are reabsorbed completely by proximal tubular epithelial cell so that they are only detectable in urine following a tubular epithelial cell dysfunction. The second group of biomarker is upregulated in renal cell in response to kidney injury. These molecules include monomeric neutrophil gelatinase associated lipocalin, that is NGAL, then DIC PF3, that is DKK3, and kidney injury molecule 1, that is KIM1, which are expressed mainly in distal and proximal tubular epithelial cell. Then hepatocyte growth factor, it is a biomarker that is upregulated in interstitial cells in response to kidney injury. A related group of biomarker that is constitutively expressed by tubular epithelial cell and then released into urine in response to AKI. So examples of this group include lysozyme enzyme N-acetyl, BD glycosaminidase, cytosolic protein lactase dehydrogenase, and the brush border protein GP130. Cell cycle arrest markers like insulin-like growth factor binding protein, that is IGF-BP7, and tissue inhibitors of metalloproteinase, that is TIMP2, appear also to be constitutively produced and released rapidly in response to injurious stimuli causing tubular cell stress. Then prolonged and increased expression of TIMP2 and the IGF-BP7 may be synonymous with the cell damage. Then another biomarker, which is known as CC motif chemokine ligand 14, is the member of chemokine family that is implicated in the tissue injury and repair process. So it is primarily produced by macrophages and monocytes and is thought to play important role in recruiting and activating monocytes and other leukocyte subtype to site of injury and infection in various organ systems, including the kidney. Lastly, biomarkers may be emitted by inflammatory cell residing or entering the kidney during AKI. Examples include interleukin 18, which is released by macrophage and neutrophil passing through kidney, and interleukin 9, which is produced by CD4 T cell and released into urine in patients with acute interstitial nephritis. So another method of categorizing renal biomarker is to stratify them based on their characteristics. So some biomarkers primarily reflect glomerular filtration, that is serum cystatin C, and then proencaphalin A. Then glomerular integrity like albuminuria and proteinuria. Then tubular stress like IGFBP and TIMP2. Tubular damage marker include NGAL, KIM1, and NAG, liver fatty acid binding protein. Then intrarenal inflammation like interleukin 18, interleukin 9, repair mechanisms is CCL40. So now the further classification of the biomarker is based on whether they are functional biomarker, stress biomarker, or damage biomarker. Functional biomarker include serum creatinine, cystatin C, proencaphalin A. Stress biomarkers which are present in the urine is this DKK3 and then TIMP2, IGF-B7. Damage biomarkers include CCL14, hepcidin, interleukin 18, NGAL, interleukin 9, then KIM1, AAP, fatty acid binding protein, ALP, NAG, hepatocyte growth factor, and gamma GT. Then damage biomarkers, which are present in the serum, is including hepcidin, L fatty acid binding protein, and NGAL. Now, use of bio. So these biomarkers are helping the early diagnosis of AKI. Means we can diagnose AKI when it is not evident. Means there is not no evidence of actually acute kidney injury or without any change in the serum creatinine. That means when this acute kidney injury is in the subclinical stage, we can identify this type of AKI by testing biomarkers like NGAL, TIM2, and IGF-BP7. Then determining AKI etiology. AKI is not a single disease, but rather multifactorial syndrome, which is characterized by the wide spectrum of pathophysiological processes. And some biomarkers have proven to be useful in identifying main etiology and excluding potential causes. So, for instance, in patient with if somebody is in acute decompensated heart failure, which we are treating with diuretic, then we are finding the next day the patient's creatinine is raised. So sometimes because of this rise in creatinine, we are stopping this diuretic. But later we found that when they are because of the stopping diuretics, when the patient had this gone into further decongestion, then in this context uh, is associated with the. However, there is evidence that further decongestion in this context is associated with the reduced mortality despite the apparent functional AKI. That means if we won't stop diuretics just just by seeing creatinine, then that will be associated with the reduced mortality. So observational studies have revealed that serum creatinine rise was often not associated with increase in the other biomarkers like urinary NAG, KIM1, and NGAL. So, thus, determining whether the increase in serum creatinine represents the actual kidney damage or simply reflects diuretic induced free water removal is useful. So, similarly, when somebody is admitted to us with the HRS, then somebody is admitted to us with the cirrhosis, and if the creatinine rise, then it's very difficult to say whether this rise in creatinine is because of the HRS or other type of the AK. So for that, the recent expert consequences meeting by Acute Disease Quality Initiative and International Club of Ascites concluded that combined use of functional and functional, that is serum creatinine and cystatin C, and damage biomarkers, that is NGAL and albuminuria, enables more accurate differential diagnosis of etiology and mechanism of AKI in patients with cirrhosis and potentially enable the identification of AKI subphenotype suitable for specific therapeutic intervention. Now, the next is urinary interleukin 9. It has emerged as biomarker, which is suggestive of diagnosis of acute interstitial nephritis versus acute cubular injury, glomerular disease, and diabetic kidney disease. So, among patients with acute interstitial nephritis, those with high interleukin 9 level benefited most from the therapy with the corticosteroid. Now, the prediction of persistent AKI. So the distinction between transient, that is less than 48 hours, and persistent, that is more than 48 hours AKI, is clinically important as the persistent AKI is associated with worse outcome. For instance, the use of renal replacement therapy is typically reserved for patients with persistent AKI. The urinary biomarkers like CCL14 was found to identify those with high risk of delayed recovery. Preoperative ratio of urinary DKK3 to creatinine concentration greater than 4 was associated with significantly high risk of persistent kidney dysfunction and dialysis dependency. Now the prediction of RRT. Recipient of RRT is common endpoint of biomarker analysis. So several biomarkers including NGAL, interleukin 18, cystatin C, cell cycle arrest markers, and CCL14 is associated with RRT initiation. So analysis of data from the protocolized care for early septic shock, that is process trial, showed that patient who still had urinary TIMP2 or IGF-BP7 concentration more than 0.7 After receiving fluid resuscitation, they are at high risk of composite endpoint of the progression to AKI stage 2 or 3, and there are high chances that patient will receive RRT, and the mortality also increase. Now, prediction of the long-term outcome after AKI. Patients surviving an endpoint episode of AKI, they are at high risk of chronic kidney disease, cardiovascular comorbidities, and reduced long-term survival. So serum creatinine has limited role in indicating kidney health in acute setting, in particular in patient with muscle wasting and persistent comorbidities. While NGAL was not predictive, CCL14 had fair prediction ability, and TM2 and IGF-BP7 had best predictive ability for renal non-recovery. Elevated plasma cystatin C, plasma NGAL, mu NGAL, proencaphalin A level at ICU discharge were associated with highest risk of 1 year all-cause mortality, including patients with low serum creatinine results at discharge. There is association between urinary kidney injury biomarker, including NGAL, and interleukin 18, KIM1, and liver type fatty acid binding protein, and albumin and all-cause mortality. So, the identification of AKI subtype. It is now clear that syndrome of AKI is comprised of numerous subphenotypes which can be identified and discriminated through shared features such as etiology, cause, risk factor, and diagnostic features and prognosis. Importantly, identified subphenotype may behave differently in response to selected intervention. So existing and emerging biomarkers are likely to have prominent role in discriminating subphenotype of AKI directly if they are specific for particular subphenotype, or indirectly if the absence of detectable biomarker exclude that subphenotype. So expanding the diagnostic criteria of AKI by integrating biomarkers of kidney stress and damage will not only embrace the concept of subclinical AKI, but also enable further differentiation of subphenotype of AKI. Now, the biomarkers guided management. Several studies have shown benefit associated with the use of functional and damage and stress biomarker, in particularly after surgery and in the context of nephrotoxin exposure. The prevention of cardiac surgery associated with AKI by implementing KDIGO guideline in high-risk patients identified by biomarkers, that is pre-AKI trial, was the first, which used biomarker to identify high-risk patients. Patient with the urinary, that is TIM2 and IGF-BP7 concentration more than zero point 0.7 were randomized to receive care bundle, which was based on recommendation by Kidney Disease Improving Global Outcome Expert Panel, with focus on hemodynamic and fluid optimization and avoidance of nephrotoxic group. The proportion of AKI, and they have found that when they have used these biomarkers and they followed that care bundle, then they have found that the proportion of AKI was actually reduced in the intervention group. Then the next trial was Big Pack trial, that is biomarker guided intervention to prevent AKI after major surgery. The similar care bundle, including early optimization of the fluid and maintenance of the perfusion pressure, was implemented by testing the biomarkers like TIM2 and IGF-BP7, and they also have found that the risk of AKI was reduced in intervention group. So biomarker guided management in sepsis was evaluated in LAPIS trial. This study compared three-level kidney sparing sepsis bundle based on KDIGO recommendation and guided by risk stratification using serial measurement of urinary biomarkers in patients with sepsis. But the study was unfortunately terminated prematurely and concluded that this strategy was, but they have concluded that this strategy was feasible and safe. Nephrotoxin contribute about 30% of AKI cases in critically ill patients. So measurement of this biomarker has been shown to support drug stewardship, informing patient prescription, drug dosing, as well as application of supportive measure. So in real world evaluation, the use of urinary TIM2 and IJBP7 as a AKI risk screening tool resulted in differential application of various components of AKI management those with positive test results. So NGAL has been evaluated for cisplatin associated AKI and demonstrated that NGAL facilitated recognition of AKI in 4.5 days sooner than the serum creatinine for cisplatin associated AKI. In patients with amphotericin associated AKI, NGAL detected the event about 3 days sooner than the serum creatinine. Now, biomarkers adoption in the clinical practice. The increasing ability of the measure to new AKI biomarkers and the observation that they are likely identify earlier phases of AKI and allow the subphenotype has opened the door to personalized medicine for the AKI. But in the opinion of many experts, this approach is ready for daily use in conjunction with the traditional test. However, adoption into routine practice has been slow. So the reason vary between the institution and but includes several factors. First, there is heterogeneity in the performance of various biomarkers in different clinical studies depending on the patient's cohort, timing of measurement, chosen cutoff value, and lab techniques and confounding factor. Second, specific cutoff have not been determined for all biomarkers. Third, standardized assay and point of care testing device are not available for all biomarkers, and not biomarker tests are approved by regular bodies for clinical use. Fourth, financial costs are also mentioned as a barrier. So 23rd ADQI panel concluded that combination of damage plus functional biomarker along with clinical information improved the diagnostic accuracy of AKI, allowed the recognition of different pathophysiological process, and could discriminate AKI etiology and serve to assess AKI severity. Further, expert panel proposed that clinical information enriched by damage and functional biomarker could lead to more sensitive AKI definition and assist the prevention and management of AKI. However, expert panel was not able to issue specific recommendation for all potential clinical scenarios. Thank you, guys.